Okay, good morning, good afternoon, good evening to everyone who's joined us for our part 3 in the series on decolonizing global health, perspectives from nurses and midwives. My name is Crystal Lander. I'm the Executive Director of Global Affairs at Pathfinder International, a global public health organization dedicated to ensuring that every woman, every youth around the world has access to sexual and reproductive health care. So it is my pleasure to serve as your moderator today and as your host really for this amazing discussion. You have met some of our speakers in our first series. It was so successful that we added a part 2 and part 3 to keep this conversation going, and it's just that, a conversation. We appreciate you being with us on this ride, as we don't pretend to know all the answers. It's about bringing forth the tough questions and challenging the systems and the structures that we know are preventing us from meeting the needs of those around the world. It really is that simple. So today we will continue that conversation. We will look to deconstruct the narrative, the policies, social inequities around race, class, sexism, and power dynamics, and we will really focus today again on some solutions. So we hope you will join us in the conversation in the chat box. The information's there. I want to start by thanking our partners on this ride. It has been phenomenal. I've been so blessed to be a part of it. See Global Health, the Frontline Health Workers Coalition, the G4 Alliance, IntraHealth International, Nursing Now, Partners in Health, and Smile Train. So again, thank you, and thanks for joining us. Now we're going to get into our speakers and discussants for today. We have Angela Nguku, founder and executive director of the White Ribbon Alliance in Kenya. She's a passionate maternal, newborn, and adolescent health champion. Her career spans more than 15 years of dedicated work to ending preventable maternal newborn deaths globally and amplifying the voices of marginalized and vulnerable populations in Kenya and throughout Africa and frankly around the world. We have Professor Edward Kumakech, who's the Dean and Faculty of Health Sciences at Lira University. For over 17 years, Professor Kumakech has experience working at the university level for nursing and midwifery education in Uganda. In his mainstay field of biomedical, epidemiological, and quantitative research on maternal, newborn, child, and women's health, from infectious disease to cancers. And then we have Tembi Mugore, who is the senior advisor at IntraHealth International. Tembi has an expansive experience and expertise in policy and strategy development, clinical service delivery, strengthening health systems, strengthening health systems, and integration of maternal, child health, family planning, and HIV services. So you can tell we have a diverse group here, and that's exactly what we wanted. We want to hear different perspectives on this conversation. So I want to, start off with the big question. In what ways has racism, colonialism, and sexism shaped global health? And Tembi, I want to kick it off to you, specifically around our training. And in some of our last dialogues, we talked about even the books, down to the books being colonial and racist by training. But how has the training in your experience been really shaped what global health looks like today?
Okay, thank you. Thank you, Crystal, for that question. I think it's a big question. It's a question that needs to be looked at from different angles in my perspective. But I'll just give a little bit of my understanding of where we are coming from. I think we are coming from where, and I'm going to talk in terms of colonialism, because racism is grounded in that, and the origins of sexism, particularly in developing countries or low-income countries, emanates from colonialism. So I'm going to explain that there were two groups, basically two main groups of colonizers. Let me call them that. One is the wealth seekers, the people that were coming and seeking wealth. On the other hand were the missionary group, the ones that sought to do good, that sought to convert, that sought to save and do what they believed was right. And what we find as part of the evolution is that on the wealth seekers, we established colonial governments, they also did establish hospitals. They also decided that they needed health workers and professional health workers. So they did establish training or education institutes. And same as the missionaries, who mainly went rural to serve a rural population, did establish these missionary enclaves that provided basic education, that provided healthcare through hospitals. That also did, some of them did set up training institutions. And this is where, again, at that particular stage and point, at the start, inequities began. The missionary schools mainly did train a lower cadre of nurses and midwives, enrolled nurses and enrolled midwives, whilst the big urban centers where these hospitals were trained a much higher cadre, was the registered nurse. So you had a basic rural population being served mostly by the enrolled nurse, and you had the registered nurses that could progress as training goes. So I just thought I should put that where the urban and the rural started, and the inequities that came from education as far as that was concerned. But I think it's important for us at this stage, because we did define, we talked about the textbooks, like you said, Crystal, we talked about the textbooks. Yes, they just brought what they knew. They brought their background. They brought what was existent. There were no textbooks written for training within the low-income countries' context at that particular stage and point. But I think we need to examine, was it all good, or was it all bad? I think I actually would like to advance this discussion as we go on with the discussion, to avoid brushing everything or tattooing everything with the word bad. And also, on the other hand, not excusing things that should not have happened, not excusing inequities and saying they should have happened. And on the good side, I think the establishment of education itself was an important step. Professionalizing a health cadre who communities could trust, who communities believed that if they were wearing that uniform and they were registered nurses, you could rely on that they did understand your health needs and they could provide that health care. And I think that's important. I think the other thing that was important is the establishment of regulatory councils. I think when you are starting, you don't want everybody to be the expert without some form of really standards that are laid down that say this is what qualifies you. I think I wanted to put that message across. And whilst I'm putting that message across, I think the other thing that we need to say, to also look at, is what did it mean in terms of the education of health cadres? What was missing? I think one of the things that missed out of that is that almost the educators were important. The learners were local. The educators were important with their textbooks, with what they had. Where is the gold standard? Their gold standard was obviously, if you were the British colonizer, was based on the British premise of education, and that's what was followed and perpetuated for years. There really was very limited capacity building for curriculum designers, for educators from within the local context. The generation of knowledge that goes into translate into textbooks, was also the research. That funding was held by the colonizers, the opportunities for research the opportunities for generating knowledge and evidence was, whilst it was happening in the low-income countries, in the colonies, it was being exported back in translating into textbooks and re-exported back now as refined knowledge with very, very limited participation. I think the other thing that is really very important and why I welcome this debate is a key recognition that not everything is good and not everything is bad, and that we need to look at how do we promote the good and move forward with it, and how do we deconstruct the not so bad. I think as we moved forward, as the global health came in and global education came in, there were opportunities for people like me to go and train in former colonial countries and go back with my training, and that was one. Did I perpetuate continued colonialism in a different form? Probably I did, because I brought those ideas from my own training. That's one thing I think that needs to be examined and examined thoroughly. The other thing that also did happen with this perpetuation is we saw a flurry, and there are so many networks of education, of global education, that are like all over. If you just Google it, you'll find so many networks that have sprouted to try and address this same issue, to try and address the issue of decolonizing global health education. But unfortunately, we are still not on the playing field with that, because we still have a lot of high-income countries, students parachuting into low-income and middle-income countries for their global health experience. We do not have the same traffic from low-income countries to high-income countries for the same experience. I think unless we really look at what do we mean, are we saying global health is all about low-income countries, or are we saying that's where they get the experience, better experience, or they can have hands-on because they are working in limited human resource settings? I think that's an area that needs to be looked at. That's an area that has been perpetuated over the years. Whilst we are saying, yes, let's decolonize, let's look at that, we are just saying, let's open up. For me, let's open up another form of colonialism that allows, that allows, again, high-income countries, because they are more resourced, they are better resourced, to parachute their volunteers or students for internships in low-income countries with very little happening the other side. I think, I'm not saying it's not happening, it is happening, but it could happen at a much, much larger scale. I think
Miss Tembi, you got us started. You have said so much there, but because I want to pause you because I want to come back. You have a lot of points in here that we have to, that I don't think we brought up before, that we really have to do it, to look in and unpack. The parachuting in, so that, you know, we learn from, again, people on the ground, and then we get to take our knowledge back. That's a huge point, and as well-meaning as it may be, is that the right way we should be doing this? And you've given us a history lesson and reminding, I know many of us, you know it, but never think about the role missionaries played in this. A lot of, like you said, a lot of good things, but the impact of even things like bringing your own books. Now that becomes the norm for a little kid in Kenya. Now the book looks like, no pages look like him, because that book came from, Kansas. So that's powerful. And I mean, growing up in the US, you would have like send books to Africa movements. those books probably, they didn't look like me in the US, so I'm sure they didn't look like the kids in Africa. So how we've perpetuated this over years without even thinking about it from that good missionary point of view, we got to come back to that because it's a lot there. And I want us to make sure we come back to that. But I want to, switch over and get the professor involved in this conversation a bit. Again, same question. In education overall, I mean, Tembi started about the training is a part of the education system, but particularly in the education from the start. She talked about missionaries involved in education, and the wealth builders are involved in education. They needed schools for their kids too and their families. How has racism, colonialism, and even sexism shaped global health in that particular field of just in education alone? And I know you have a lot of extensive experience in this, but can you give us a little bit from your perspective?
Yes, thank you so much. When we talk about how colonialism, racism, and sexism has shaped global health, we should start looking at how the different professions within health are perceived and how this originated from racism, colonialism, and sexism. For example, professions like medical doctor or physicians is perceived superior compared to other professions. And then you find also professions like physician and laboratory medicine work is perceived to be for male, and then the nursing and midwifery is perceived to be for females. And of course, we know this very well now has caused a lot of problems because people join medicine or nursing or laboratory medicine or pharmacy, not just because you are superior or inferior to the other. So all this differentiation and segregation has originated from the colonialism perspective that, for example, nursing is just assistance to physicians' work, and then nurses are not intelligent enough compared to the physicians. But this is something we are seeing very different currently. If you put people and you give them the same resources, you give them the same teaching, you give them the same lessons, whether they are physicians, whether they are nurses or pharmacists, you see there's really no difference in IQ that much, no difference in emotional intelligence. I also want to see another effect in the education sector is when it comes to admission of people into the various health professions. You will find professions like nursing is taken as the last resort profession. Like when somebody has completely failed to get into the other cadres of health profession, that's when they'll say, oh, maybe you try nursing and midwifery. And therefore, it gives the professionals kind of inferior position in the community. You are not intelligent, you have failed, you are just there. So this also originated from the colonialism perspective of the different professions within health. And then when you come into the actual teaching and learning environment within schools and institutions of health, you see, for example, all the textbooks, all the teaching materials are from the colonialism. They are from the Western world. There are no indigenous knowledge materials. There are no local resources, pictures, modules, or everything that are used are from the Western world. And this already gives the learner a different perspective that anything African, anything local is bad, and everything Western is good. I want to give an example of traditional remedies that we actually know works is condemned in the universities. Learners are not exposed to this traditional medicine. And if you try to say anything about traditional medicine, you are regarded as a witch. So all these traditional cultures, even in the care, in the clinical care environment, people are forced to adopt the Western culture of care, our traditional care practices that respects culture, respect, is completely ignored. And you can imagine our old persons, the older persons who are persons, looking at the younger professionals, not showing respect during care, and so on, how they go back at the end of care. And then I also want to mention issues when it comes to access to resources. There is a big imbalance. African universities, African institutions have limited access to academic resources. For example, we don't have access to journals. They are very expensive. If there was no Hinari, for example, research are published in journals, in platforms that are not easily accessible. Look, access to research funding. There is a big imbalance. Universities in Africa cannot access funding for research at the same rate as it is for universities in the Western world. And in the end, university faculties in Africa are basically data collectors for faculties in the Western world, for the colonialists. And when it comes to publications, we cannot negotiate. If you are lucky, you are put towards the end there, you cannot be the first author on publications. And then mentorship is lacking. We don't have senior mentors. That's because we have lost that grooming right from the start. In the Western world, if a promising academician is quickly taken up, is given a junior faculty position, he gets a career development award, is mentored into research, grant writing, he grows along the profession. But here, a promising academician is sent into the patient care, is very good in clinical care, but there's no single publication, there's no single research that is done. So these are some of the inequalities, imbalances that we are seeing in the academic sector. Thank you so much.
Oh, Professor, just like Tembi, you really put a lot out there right from the beginning. The pushing out of the traditions in lieu of Western ideas, thoughts, medicine, important. I think you really hit something that, again, we haven't gotten to, which someone is already asking a question about, is the brain drain a bit of that, but also the idea of even in the U.S., or even when U.S. is, working in countries, or we tend to have these ideas around, like, so the U.S. person comes in, or, it could be UK or someone, they come in, they work with local nationals on a paper or research, and then that local national is not even the first author. That is something, these are just small things, but perpetuate the same colonialistic view, which we can do better on. I mean, I'm just glad you're calling these things out, because I know many people participating may say, oh my goodness, I was a part of that, or I did that, because it was like, oh, but they'll know this name better, so we'll put the person's name we don't know as well as the second author. But again, that is a white male usually as the first name. And frankly, we should be calling out publications that won't print a local national's name first. So if this is truly global health. So you really started. And I think the other thing about that sexism, that hidden sexism of the type of professions. Now we see this around the world. What are women's jobs versus men's job? And we know there's a difference in pay. And when you said, nurses are seen as assistants to doctors, I have to say that's how I grew up. I was taught that nurses were kind of inferior to doctors. And I don't think it was done from a malicious, it was just a stereotype. And it perpetuated and it keeps going. Somehow that nurse isn't as good as, or she would have went to medical school. When it's a lot more, there are different professions for different reasons. So some of this, is things we see around the world, but I definitely, they resonated with me. Now, Angela, the professor starts talking about the resources aren't there. And I want to just kick it over to you. We know it always comes down to money. Money for this, money for that. And, in the US, a lot of times it's like, well, why aren't local governments investing more? And so you get a lot of donor funding, which, to be honest, it comes from countries where the majority of people don't look like the countries in Africa and Asia. So what do? how does, the funding play into these perpetuating these stereotypes or keeping us not moving forward in global health? I know it's an easy question for you, but over to you.
Thank you so much, Crystal and Edward and Tembi, for going ahead. And I really concur with what they have said. And more so what Tembi was talking about, we cannot really, the foundation of sexism and racism is all colonialism. So all this is grounded from that, and that's where everything originates. And moving to what Edward was talking about, that the way even the career paths are shaped, they have a colonial history that we cannot really run away from. Let me start by saying that there's the old saying that he who pays the piper calls the tune. And I think that is exactly what is happening in the global health space, and especially in nursing and midwifery education. And not just in those two, but in every other sector, basically in global health. I must say that global health, whether it's training, whether it is research, whether it is practice, it entails partnerships between low middle income countries and the high income countries. What that means is that it's basically the colonizers coming back in a different package to say that we're actually coming to work with you to actually make things work. But what we see over and over again is the colonial hangovers. It's basically you coming to, it's neocolonialism. It's basically trying to say that you are still our slaves, you are your masters. So we have this money that we want to use to do ABCD, but at the end of the day, this is how it's supposed to look like. So you cannot, as Edward said, you cannot, we are going to do research. You are going, because we're in this country where the tropical diseases are, where there's no this, there's no that, you are the ones who are able to get that research. But at the end of the day, you are not the masters. You don't know how to do it. Basically, that's how it plays. You don't know how to do it. So at the end of the day, we are going to publish because I think we know English better, maybe. I'm just making assumptions. That is what normally goes in. Or we know how to write it better because we are the ones who have done it much more. What that has done is that it has left people, left very little attention being paid to the legacy of former colonial masters or relationships that have existed and the influence that it has had on the global health space. And to be honest, I'm so glad that this year, 2020, we are talking about how then do we decolonize that, because it's something that we've seen over and over again. When it comes to funding and who gets the funding and who gets the money that is coming from the West or from the high income countries, it's the other bigger question, because for you even to get that funding to do that research, you have to really like almost sweat your last. You have to prove yourself. There's a lot of proving that is not the same thing that I see when it comes now to the other people coming from the high income countries. It's very easy for them. But for you in the low middle income countries, you really have to prove yourself that you can actually make it. And you keep on being asked questions, and there's a lot of filling of these forms and doing of these things. And at the end of the day, we cannot, what that tells is that even as we speak this, we cannot ignore the fact that colonialism continues to play a key inequality. It continues to push inequalities that we are seeing in the education sector, in the research sector, in practice sector, because in global health, the whole global health and the public health space is the same. So I think, and moving forward from that, something else that I've seen that Crystal must talk about is that, and you talked about it earlier, we keep on hearing that countries in the South are not investing enough for their health, for education, for research, for all this. But what are you investing? You're already underdeveloped by colonialism. All the wealth was taken away, and now you are being looked back and you are being told, oh, you have less. You've taken away the money, you've taken away the wealth. You brought it back as small tokens, and then you come and say you are not investing enough to do this. And even the little that the low middle income countries, especially in Africa, do, we are investing. All those trained midwives and nurses, there's a lot of attrition to the West. They still go ahead to work in those countries. But when that happens, that is overlooked. It's actually deliberately overlooked. And the blame keeps on going to the countries, the African countries, that you're not doing enough. No one is really looking back, to look back and say, but wait a minute, where are they going to? And if they are going to, they are coming to our countries, what more can we do? And I talked about the same thing in our last part of this, that we need to see more of that. What the investments that are actually being done by these low middle income countries, training of people being trained. I mean, for me to be trained for 4.5 years in the university, it was investment by my government.
Oh, Angela, looks like we're losing you a little bit.
Can you hear me now?
We can hear you now. Okay, try it again. Now nothing. Okay.
She might have to come out of.
Yeah, yeah, you may have to turn off your video. Every participants, just bear with us. Angela was on a roll here. So Angela, can you try again?
Is that better?
Oh, perfect.
Can you
Yeah.
hear me now?
Yes, we can hear you perfectly. Yes.
So I was talking about the origins of the failures that we are seeing in investments, especially in African nations. We see a lot of attrition to the West, but no one really questions who trains, where do these people come from? It's an investment that has actually gone to training of these people. But at the end of the day, you receive these people, you call, you keep on calling. I see a lot of calling, oh, nurses are wanted in this country, midwives are wanted in this country, more frontline health workers are wanted in this country. But who actually thinks around, when we take away from them, what are we doing? What are we giving back? Because we should be investing exactly the same as that, as I said last, so that we can have enough to have for both Africa, Asia, and the Western world. So at the end of the day, we cannot really talk about, it's not an equal play, Crystal. It's not equal play at the end of the day. It is a system that is still upholds the whole mandate of colonialism. It is actually not even new. I don't even think it's neo-colonialism. I think just colonial among us. We are still colonized. We assume, we think that we are actually in the global health space, that we are free. But I feel like we are really, really, really still colonized, because if you look at the funding, if you are going to apply for research, if I'm going to apply for training, I am told you must go and do it in this country. Why can't I do it in my country and use the resources that are there? If you really are genuine, if the funding is really genuine and is meant to actually do what it's supposed to do and make the countries in the South better, why can't we be allowed to have a stake on the table to decide how it needs to look like? Because that is not the case. At the end of the day, you are told you must come and study in this country, you must do this. Basically, what you are being told is bring your knowledge here, bring your practicals here. We want to use you even as you're doing this. And when you finish, we are not even sure we want you to go back. There are places you can actually do that. Who is actually thinking of these countries? So over and over, we are seeing more and more a system that is really not interested to really make changes. I feel like it is a system that is still perpetuating what is started in a different way, and that needs to change.
Oh, Angela, you three are like on a roll this for me in the morning, and just so much there. And I think I'm speaking for the participants on the line. I think many of us have seen these in the same things you're talking about in different parts of our work, and that's why they're on the line. They want to really focus on like, how can we fix it? Not to say this is going to be easy. Colonialism didn't start over, just yesterday, and it's not going to end tomorrow. But I think you all have brought up so much, and you went back to a theme that Tembi talked about, which is wealth seekers. So wealth seekers have taken away so much, and they're still taking away, the strongest and those who are educated from the local populations. And we turn around to those countries and say, okay, why aren't you doing better? Even though we've left you behind with infrastructure issues and a lot of taking away some of your natural resources. It really is, it doesn't feel fair. It's kind of like you drained me for everything, and then you say, why am I doing better? So this is challenging. Tembi, I'm going to come back to you. So we definitely, we all get it. We understand a bit more, and thank you for laying it out, kind of like these two separate groups who've gone through. I think many of us have, heard of missionary schools and hospitals and all that. We visited them. And then you had these other things, and particularly in the rural areas. And we know a lot of this, like you said, this wasn't necessarily done for a negative reason. People came out and shared their stories, all sorts of things for different religious reasons, Peace Corps even, like all of these programs are seen as positive. But when it really comes down to it, we now know that while it may be positive intentions, the leave behinds may not be so positive. So how can we, as an international community, improve this pre-service education? How do we elevate things so that it's more reflective of local partners, knowing that the world has been opened up. We have all seen and loved now Africa, Asia, and Latin America. That's not going away. People are still going to come and study and visit and all these other things. We want them to. Tourism is wonderful. We want them to go be, and our global health partners, we love these countries and we work there and we connect there. But how can we be a part of the positive change, particularly as it relates to the training programs, and training being not necessarily just a formal in programs, but our trainings that we do as part of these NGOs and all this other stuff. So how do we do better with that?
Thank you, Crystal. I think transforming education, transforming pre-service education, including in-service education in countries, is a journey in progress. Let's look at its origins. Let's look at where it started from. I think I just want to put out there that WHO does have standards for health workforce education that are very, very clear, that were developed through a consultative process that brought different stakeholders to the table. And I think those standards, actually their intent was that they provide that evidence-based guidance to development of, or to transforming nursing and midwifery education, or to provide the basis for in-country adaptation for nursing and midwifery education. I think I'm saying it's a journey in progress, and I'm also seeing opportunities for change. But before we go far, I always say, where should change be driven from? Should it be driven by the colonizer who goes and says, oh no, we got it wrong, we are sorry, here we are, we want to change? Or should it be driven by the colonized? I think there has to be a change in mindset between the two. A change in mindset where the colonized take the initiative to say, we don't want it to happen. Be part of that narrative that determines the change that will come. I think Angela did talk about the finding dynamics and the differences. And the colonizers who recognize that we are perpetuating colonialism, we are perpetuating what we don't want, coming to the table and saying, yes, we acknowledge that we want to be able to listen than to give. Unfortunately, sometimes it doesn't work like that because of the funding streams. There have been networks, there have been initiatives, I think you know about NEPI, you know about MEPI, that sometimes don't go very far. But one of the things that I see that is important is mutual respect in partnering, in partnerships. People listen to each other. The way we approach education, the way we approach curriculum development might not fit the gold standards of the West, but might help to define the gold standards in that particular country. And I think that that's one thing that has to be very, very clear, that we are agreeing, we are accepting that there is room for change, there is room for transforming, that the global standards actually mention that curricula or the competent health worker that is produced should be able to serve the population that they're serving. I think that's one. And I think where I'm also seeing opportunity is this whole transformation from the didactic approaches to education to more a competency-based, holistic. And I was saying to somebody, I'm seeing an opportunity there because each country will have to define what competencies and how do you measure them? Because at the end of the day, it's not just the curricula, it's not just the training materials in the classroom, it's also the clinical areas, the clinical environment where these competencies will be acquired or where these competencies will be applied. And I just have a feeling that once in the process of defining that, we might actually cut across where we are allocating 40% of the, we are in a country where HIV is a big problem, and yet you are allocating a big percentage of your learning outcomes towards management of myocardial infarction and chronic obstructive airways diseases at the expense of HIV or at the expense of reproductive health. That is because you want that curriculum, because you are measuring the gold standard against a curriculum or against a British or an American, or because you feel that's the best, that's more superior. People have a right to a certain level of education. I think we need to deconstruct what we mean by quality education. Is quality because we're checking the boxes against standards that were developed in the West, or we are checking the boxes against standards that were developed in that particular country. I think I would also like to see where standard competencies is outlined, for instance, by ICM for midwives, competencies that are outlined or standards that are outlined in the various documents. I would like to see what we are learning from them. Have we evaluated them to the extent that, what do they mean at a country level? Have we really evaluated that they are responsive to the needs of the population, which was the whole intent right from the beginning? Or are we evaluating them with that lens that they meet quality as we defined it, as we define it in the West? I think I want to pause there with those thoughts. There is need, that transformation is happening, but whilst the transformation is happening, it provides an opportunity for us to kind of say, here we go, here we need to pause and relook at this. Are we perpetuating? Are we at the end of it going to end up with the same and same? Who are we training for? And for me, that's a fundamental question.
So you have a lot of good things in here. I wanted to make sure people heard you again on those who have done this well with the pre-service. Could you name those organizations again, or the programs?
Right from the beginning, well, I can only talk for IntraHealth because that's who I work with. But right from the beginning, there has been, I think, the new partnership initiative, MEPI, that came in response to HIV and MEPI. They did some good work in transforming pre-service education, including the management of pre-service education and building capacity of pre-service education. We have also, as IntraHealth, worked in Mali, in very rural northern Mali, vulnerable population, to set up a pre-service education competency-based school. I've seen curricula in Tanzania, I'm not 100% sure who supported that. That is written in a way that actually describes and defines learning outcomes. And it's written in terms of, the teaching might be slightly different, but the curricula itself, when you look at it, it actually does spell out learning outcomes in terms of the knowledge, the skills, and the attitudes that they should have. So there is transformation going out there.
Well, that's good, and I'm glad that you are sharing those. And please share in the chat box if you have other examples of pre-service curriculum that's going well. Again, we're here to learn and to be better. Okay, Edward, I want to get back to you because both Tembi and Angela talked about basically the power dynamics. It comes down to money in a lot of ways. So wanted to look at you and really talk about this in a clinical setting. You brought this up when it comes to the cost of things and setting up the right systems and all those things. We know they cost money. We know that it's difficult, but how do we address those clinical settings, and particularly maybe even in the policy space? Like, what should we be doing so that the resources are there in country versus, you know, again, this idea that we have to go outside of the countries where we're working to get this certifications and get the real training around those things.
Yes, thank you so much. I'm happy you raised that point, because that issue of not seeing nurses and midwives in positions of leadership and in policy positions within the health system is a problem across Africa. And I want to say that it is a silent issue of sexism and gender discrimination against women. It is just because majority of nurses and midwife professionals are women. And because of that, our colleagues in other professions, the medical doctors, who are majority male, are basically exacting some forms of discrimination against women by not giving the nurses and midwives positions of leadership, positions of policy making areas. And I think the solutions comes back to trying to remove this perpetual colonial mentality that nurses, midwives, and women are not smart enough. Nurses and midwives, who are majority women, are not well educated. They are just assistant to physicians. They cannot make good decisions. They cannot make good leaders. We need to advocate to remove that mentality in our colleagues, fellow nurses and midwives, in our professional colleagues, the medical doctors, the pharmacists, and the laboratory professionals. We also have to look at issues of empowerment of women generally. You know, when you are not given position of leadership, policy making space, definitely the returns, income, salaries are very low. Conditions of nurses and midwives are very appalling across different African countries, just because they are denied these positions which earn money. So some of the solutions that I'm suggesting is definitely multidisciplinary dialogue. And we need our colonial masters to assist us in setting this space, forum, where the nurses, the doctors, the pharmacists, the physicians, they sit together and dialogue on what roles can the nurses play, which positions of leadership should be given to the nurses. Leave alone the fact that they are women. Leave alone the fact that they are mothers. They are educated enough to hold that position. They may have the enough experience to hold that position. We need to have multi-professional dialogue within the global health space. Another thing I wanted to say is we need support from our colonial masters to empower trade unions for nurses and midwives. Trade unions for nurses and midwives that can actually advocate for positions that actually are supposed to be occupied by nurses and midwives. In my country, Uganda, the structure of the health system is very clear. And even the positions that we know are meant for nurses and midwives, but you find they're occupied by medical doctors. And no one raises a question to say, why is this position meant for a nurse occupied by a doctor? We need our colonial masters, we need partnerships in global health to advocate for positions that are meant for nurses and midwives, regardless of the fact that they are mainly women. I also want to say we need partnership to introduce educations that can make nurses and midwives be seen as decision makers. For example, I know in the US and in the United Kingdom, there is this education of nurse practitioners, where the nurses are actually seeing patients, making decisions, and there are very many success stories, patients being happy, patients feeling that they are not overcharged for medical care. They feel like they are being cared for very well. This kind of education has to be introduced in Africa so that our society also begin to see that nurses are educated enough. They can make correct decisions. They can treat you and you can get cured. They can care for you and you walk back when you are happy. We also want to see how funding streams coming out targeting nurses. You look at fundings from National Institute of Health from the US. Everything is medicine, this and that. There are very few funding streams targeted for nurses. Unless we have enough of this, so that we give opportunities nurses to express themselves, to conduct research, to publish, to appear as first authors, to author textbooks that people will read and appreciate. And then that's when we begin to see the positions of nurses, the role of nurses being appreciated globally. And I want also to say that we need to support nurses to participate in politics. We want to see a minister of health who is a nurse or a midwife. Why not? We have seen this happen in other countries. You know, unless we support nurses, we partner with the nurses and midwives to lift them into that position of making decisions, allocating resources. That's when we can see these issues ending. And then lastly, I want to say that, you know, healthcare is a multi-professional role. The doctor has his or her role to play. The nurses have his or her role to play. The lab technician has his or her role to play. The pharmacist has a role to play. We need to partner with the nurses to develop performance indicators that we can say this is attributable to the nurses and midwives. Unless we develop that and say the infection rates in hospitals are very low, and we can say this is because of performance of nurses. This is reduced because of nurses. Unless we cut out that very clearly, the society will continue to see nurses as just people who are assisting. All the success stories are attributed to the medical doctors. All the success stories are attributed to the pharmacists. All the cure is attributed to the laboratory, and the nurses just remain behind there. I submit.
Edward, fantastic. And you hit so many important points. I do have a quick follow-up. So I see it in the Q&A, and a lot is around, and this came up in our last discussion, is the role of these international bodies of nurses and all, and how they tend to be very Western focused. Well, then what happens to the role, you know, of nurses in Asia and Africa? Where is their voice in all of this? Could you talk a little bit about the role these international nursing bodies play?
Yeah, thank you so much. The International Confederation of Midwives, for example, ICN, the Confederation of Nurses, these are bodies that should help nurses globally to lift the image of nurses, to lift the image of the profession, to showcase examples of things that nurses are doing across the globe, so that the society begins to appreciate nursing as a profession. I have known nurses and midwives during primary education, secondary education, who are excellent, intellectually excellent. And then the person becomes a nurse, and then people look at, oh, this is not good enough. It's not fair at all. It's not fair at all. Judging people just because of the profession that they are engaged in to serve mankind. I think the international nursing bodies, international midwifery bodies have to do a lot to raise the image of nurses and midwives, especially those working in African settings. I submit.
Great. So Angela, Edward talks a lot about this. He comes back to money and eventually power. And we know a lot of this happens at different conferences and meetings and side discussions. So I wanted you to talk a little bit about how can we increase this power for nurses and midwives so that they control their own destiny a little bit? And how are the current models, funding models, are there opportunities there? Or do we need a whole different model? So I guess a little bit is like, okay, what's the next step with around these models of funding? And can we do what Edward said? Can nurses and midwives break through with the current models?
Thank you, Crystal. Interesting discussion. I will start by telling you that with the current models, until we deconstruct the current approaches and models, I don't see us breaking through. And the reason I say that is because if you look at, for example, the way research is funded, as Edward is talking about, It's actually funded, you have to be, if you are from the low middle income countries, let me say, if you are from a country like Kenya or Africa, you must be linked to somebody or some institution in the West for you to be able to propagate whatever you are. And a lot of times you know that research is quite expensive, and the things that you want to study might actually something that is really money and time intensive. But then you are told that you have to be linked to someone else or some other specialty out there for you to be able actually to be funded to do the work that you want to do. If we continue that narrative, I can tell you for free that we are not going to go anywhere. We need to deconstruct. We need actually to even cut that table again and maybe shape it again so that when we're making decisions around that table, we have a totally new table that is really accommodating the nurses and the midwives in the East, in the South, and also the nurses and midwives and other players in the global health space in the West. We know that there's very little knowledge that has been okay, there's a lot of knowledge in Africa, for example, in Asia, but this, for it to be packaged, as Edward is saying and Tembi is saying, for it to actually see the light of day in the journals, it's very hard because it needs money. It needs actually almost feels like it needs your name to actually resonate with those who are in that, the names in those sites for you to actually land in those journals and such. And yet we know that, you and me know that the African countries, the Asian countries, it's a hotbed of innovation. There are so many innovative things that are really taking place in these countries, but they have not seen the light of day in these journals because they're expensive. We cannot be able to make it to those places and unless we are paired, unless we are twins, unless we are paired with someone else to actually be able to see that, to do that. And even when that funding comes, Christopher, for these approaches, for this research to really take place, for the nurses and midwives to really embrace it, for them to even advance whatever they are doing, it comes with strings attached, as I said earlier. So this unfair distribution, as Edward is talking about, authorship credit within the research partnerships are always not linked to the South. They are always linked to the, you have to start by somebody who is in the West for it to come to the South and all that, and that is not really fair. If we continue like this, I can tell you that nurses and midwives and other players in the global health space in the South are really demotivated. So for me, I'm going to suggest a few things that I really feel, if we really mean to decolonize or democratize and really make things work going forward, we must have a deliberate mind shift. We must rethink the way the current the research partnership, for example, the funding for the same are organized. Of course, we know they're organized to better or to benefit a better resourced player, because at the end of the day, they are the ones who have the money. They are the ones who decide what needs to be done. So if we are to do that, then we have to rethink, we have to think. And we need to rehistorize. I don't know whether there's a word like repackaging history or historizing global health. We need to look at it in a very different perspective. We need to be more deliberate, more targeted in transforming what is for us to get what is needed. We need practical models, research funding models that must be ready for a reset. We need to press the reset button, for example. And that will call for a mindset change in terms of who decides what needs to be, for example, researched on. What is the context? Who decides the authorship? Where does the funding come from? And is that funding, if it's really, really going to benefit the broader people, the broader group, that is the broader partnership. Can we make it more equitable? Can it be more equitable? Can we have a change in attitude? We really need to always have at the back of our minds, even as we go forward, that colonialism has played a role in where we are today. And for us to do that, we must decolonize our minds. We must rethink again and stop that. Then for global health education funders and organizations, there needs to be a change of mindset that colonialism was real, it is real, and this will mean that changing who sits on that table again, who sits on the leadership table, and how big is the table, how small is the table for the people coming from the low middle income countries? Because a lot of time, Crystal, we see research, we see call for proposals for a research something on ABCD, but maybe that is not what is needed. In a country like Kenya, for example, if you tell me to do something that is really not what is the people of this country need, why are you asking me? And yet you want to pull me to it because the money is there and because you want to say that you actually did it with actually, you almost look like a flower girl. You did it with somebody coming from this country and so and so. So you tag me to something that is really needed in this country. Can we really be honest enough to say this funding must benefit the countries the need must be there, not just anything. You cannot just come and start anything. And
Angela, can I just push you a little bit on that point? So should that decision be made? Should it be ministries of health or government saying, we don't want this research done here? Is it on the donors? Where do we need to be inputting a bit more to say, this isn't the right research, or this isn't even necessary, but this other thing is, if you want to do something here?
I will say on both sides. If we are genuine enough, for example, if we have funders, organizations that are really supporting nursing and midwifery education, and let's say, or basically the global health education in general, we must be honest enough to say, what is the need? I can tell you it has not been honest. But again, the ministries of health and organizations working and institutions working in these countries, for example, in the low middle income countries, then they should be honest enough to say, this is what we can take. But a lot of times there's a lot of power play. There's a lot of power dynamics that come to play. There's a lot of almost like, if you don't do this, we are not going to do this. That needs to come out, and we need to be able to expose that, because we know that is what is happening. We are forced to do things that are not what is needed. We need to study the context. What are the needs? What are the realities? What is needed? Why invest in something like, for example, plague that was eradicated many years ago, when we have a current crisis of COVID, for example, or something like malaria that is really killing our people? Why can't we invest in something that is really needed at the end of the day? Then I think we also need, as Edward and Tembi said, we need a leadership shift. The current leadership at the global health space, where the agenda setting takes place, surely does not reflect the diversity of people of these institutions, especially in the South. It has to be intentional. It has to be deliberate. We know that there's a lot, knowledge can never be unidirectional. Knowledge is always multidirectional. So this idea that the global North should always be on the forefront of the global South should change. We must be able to learn from each other. And that means even the way funding is organized, we should be able to say, actually, they can actually do it on their own, and then we'll support them with the funding, because we took away all their money during the colonial days and we gathered all the wealth, and now we need to come back so that we can be able to grow all of us together. And by the way, if we don't do that, we have seen something like COVID teaching us that at the end of the day, we need each other. One global crisis in one part of the world will affect all of us. So whether we like it or not, it's a time we need to reset that. And we need to ensure that even discussions can be driven by the South. Who say that they all have to come from the North? Who say that we do not have the knowledge? And more to that, the gender disparities that Edward was talking about in the global health leadership need to be addressed and remedied. There's a lot of that disparity. We hear people talking, there are women on the table, there are men on the table, but look at it critically. A lot of the time it's actually, it's almost, we cannot not talk about sexism when it comes to global health, Crystal. We need to almost dismantle those power and gender issues, gender power plays that come into being. Dismantle the South, North, and come on the table and say we are living on this one big planet that needs all of us. And for this health, for us to really get health for all and actually advance, we must all be on the table discussing things that matter. We have different needs across board, and those needs need to be guided by the context that we live in. And lastly, we need to have a knowledge shift. We need to have a whole, what can I say? We need to always have at the back of our mind that knowledge coming from all of us is important. I was so shocked, and I'll give this example, that when I had, for example, the COVID cure from Madagascar, for example, it was shut down. The global media, the Western media came and shut it down like it's nothing. But I'm sure if it was something that had come from the North, we would always be seeing all over the place and people talking about how we need to try it. Why can't we appreciate that even Africa or even Asia has something to offer? Or every time I see news, it's all about these bad things coming from, these ones, they did this, there's a lot of disrespect in health facilities in African countries and the like. We know it also happens in the West. So why don't we just even look at what is good and perpetuate the same as much as we are perpetuating the bad things? Because why are we always thinking that whatever comes from Africa or Asia is bad? We need to think that and decolonize our minds. And always at the back of our mind, we must know. We must have our own honest inward reflection and a total paradigm shift from the current colonial savior mentality, thinking that we have nothing to offer here in the lower middle income countries in Africa. We need to recognize that colonialism played a role. It continues to play a role, and we must deconstruct those structures for us to move forward. Thank you.
Thank you, Angela. And we have a lot of questions, so I'm going to shift to get some of these in, and I still have a few others for you. But I think themes that we heard a lot is, one is, and if you joined us a little late, we recognize that, you know, even us as working in this field, because colonialism happened to all of us, essentially. So we can sometimes perpetuate stereotypes and bad views of things. And I know it came out as we unfortunately may just take on, you know, the bad habits of your masters. I mean, that's what happens. Why we're all here together is we know we can do better. And so we are elevating some of these issues to say, how can we address them? And that's the key thing. So I wanted everyone to make sure we've all owned that in this space, and we've owned it in our last meetings. So a couple questions, and there are a couple themes. And it talks about, sorry, I lost the question, about the hubs. It says, often, from Rachel, often great global health practitioners will point to teaching hospitals or centers of excellence as ways to shift power and learning to better reflect the context. Can discuss and share any examples of how these hubs have been successful, including on how they got the resources they need. And that goes along with the question people that Tembi brought up about NEPI. People want to know what NEPI exactly stands for so that they can look it up and follow. And if you want to just stick the link to that in the box. I will start with Angela on this one. Is there centers of excellence or other things that have worked, and do you have any examples of those? And then Edward, I'll go to you.
Thank you so much, Crystal. I will say that I've heard of that terminology since back in the days that we are creating centers of excellence. Yes, they do work, but they are short-lived because most of them are projectized. Funding is tied to a project, and they will come up with, this is how it ought to look like. There will be a lot of investments and funding coming to these centers of excellence. Then in 2, 3 years, 4 years, it's done. I mean, the sustainability aspect of it has always been the thing that I've had an issue with. How can we cannot come and fund a small center of excellence somewhere and just leave it there, and then there's no sustainability plan, there's no exit strategy, or now how is this actually going to look like if when we are gone or when the project is over. So I think the centers of excellence do work. They actually showcase what is happening, but honestly speaking, if there's no sustainability plan, there's no integration with the ministries of health. And more so, as much as I really don't have a problem with centers of excellence, I also think around equity. We are talking about equity in terms of ensuring that everyone gets the quality healthcare across the countries. Why can't we think investing much more in where we can be able to see diverse all this? I know they are mostly for training and ensuring that others can learn and actually establish the same. But as much as there's no sustainability plan, as much as governments have not bought the idea, as much as they don't just come from outside and implant it and then people leave and then they're left like that, then they might not work at the end of the day.
Great. Edward.
Yes, thank you so much. I think creating centers of excellence where we can show potentials, abilities, and good results from nurses being put in positions of leadership, taking decisions, creating research agenda is something we should advocate for moving forward. Because I think globally, right from the time of colonialism to date, I think a lot of education, training, and capacity building has happened to nurses. And I'm sure across Africa, we have very good educated nurses who can take positions of leadership, who can mentor, who can create research agenda, who can publish. And this is the thing I'm calling all of us to advocate for nurses moving forward, creating centers of excellence where we can showcase good things that can come out of nurses. I submit.
Great. Tembi.
I think I want to keep going back to how do you define a center of excellence?
Okay. Well, define it for us. Tell us what, yeah.
No, because I've had centers of excellence really formed and established. And those centers of excellence, the intent again is very good. The purpose, they're established to provide this excellence, but are you perpetuating inequities? If place A is this center of excellence that will serve a small training, because not every training institute in that country will have their students go through that center of excellence. This means you are still leaving out some places. I think if you are, for me, if you are to develop centers of excellence where you have education institutions, you need to have equitable standards applied and equity in terms of resources, in terms of faculty, in terms of what all they have. Because you want, at the end of the day, in that country, everybody to exit having had the best of what that country defines as quality education. That's really and that's my own personal view. I think they are good as models, as a start, but we need to think of fairly quick scaling up where they've worked and resources to scale up, so that they become universal in that particular country.
So we hear you. So we're saying they're not a bad thing, but we have to make sure that the definition of excellence isn't something that comes from somewhere else. It really has to be defined locally. And I think that's a good point. And it leads to a couple other questions we have around it, which is really just, kind of reflecting on ourselves. How can people from higher income countries, thinking US, UK, and all that, how can we still culturally appropriately and partner with nurse capacity building, learn locally? I mean, you said something about the drop-ins. I think those were powerful messages. How do we still love these countries, work with our partners locally, and all these things without perpetuating this, re-colonialized view of things and perpetuate the colonial structures? Like, how can we do that? And Tembi, I'm going to start with you on this one, since you brought up the fly-ins, and immediately I thought about, some of these great programs that we have, but are they really just perpetuating the same colonial stereotypes?
Sometimes that's myself having attended education in the West and working in the West, whether I am just perpetuating the same narrative. I think there is still a lot of work that needs to be done with professional associations that are the voices of a lot of nurses and midwives in their countries, to go in with a clean slate, and sometimes that is challenging, to go in with a clean slate and just ask those questions. Let them be the beginning and the drivers of that narrative. I think we come in, for as long as I feel that coming from the West, I know it's wrong, colonialism is wrong, and we need to change it, without it also coming from the other side. It's going to, we are still perpetuating colonialism indirectly. We are. I think the narrative needs to be written more from the other side. I remember saying to somebody, I was the one who was colonized. I'm the one who feels the effects of colonialism. So unless I am given that voice, that platform to air, I might not even be politically correct, but so what? Colonialism is not politically correct, particularly in what it has done in global health, particularly in the area of education. But we need to lend, we need to ensure those professional associations that are the voices of the nurses and midwives in their countries drive that narrative to the extent that they rewrite that narrative and what we want. And we would be best to listen and be responsive, to engage as partners on a playing field, as equal partners with mutual respect. Some of the things might come out that we don't like to hear, but let them come out. I think it should not be, how can we be the ones to deconstruct? I think it's how, what are those partnerships that we can build? And I think there is opportunities within the professional associations in the different countries that are very different, that should feel that they are empowered to speak, to go out of, to not be polite, let me put it that way, to not be always politically correct, and to drive the agenda. It's going to take a lot of leadership and investment in leadership for nurses, because right now what we find is within the small, within a large volume of nurses and midwives, 90% of the health workforce, about 20-25% of them are in leadership positions. And if you look at who is in those leadership positions, is your best clinical nurse, the one who is the role model. I've said to a lot of chief nursing officers, you know what, you would be best in the hospital, modeling to those young students what it is to be an excellent nurse, and you are sitting here in the office. And so I think we need to cultivate and invest in developing that leadership that is going to rewrite the narrative.
Great. And I think another thing to think about, which I hear coming up, and I've heard the speaker say today and other times, is we got to bring people to the table. We have to really reflect on what things look like. It is not on those who have been oppressed to always have the answers or to solve the problems that they didn't create. And then and then these national nursing and midwife organizations really examining the power dynamics they may exist even in those groups. And is it really reflective of their diverse membership? Do they have some implicit bias that is showing up? And I think for NGO settings, coming back to your initial point, it is really important that we show our principles. And I saw it come up on the comments that you can have a great organization with a great mission, but they hire staff who are bringing in a lot of their implicit bias and stereotypes. We have to do better with making sure, just because a staff person has visited a lot of countries doesn't mean that they don't need training on bias and colonialism before they're doing work with partners. So I think we have to own that, all of us, on those things that play a part. I want to make sure Edward and Angela talk. I want to address this last question to you. The World Health Assembly Part 2 was this week, and a lot came out, including some really positive things. We know this year's the year of the nurse. Next year will be the year of the health and care workforce, which I think is really important. And it gives us the time to keep talking about some of these issues and the really important role healthcare and healthcare workers play in moving things forward in countries. So, Angela, from a money perspective, and a policy perspective, how can WHO play a role, or what should we be doing as organizations with WHO so we make sure things don't get stuck at a policy level? And Edward, then I'm going to turn to you to ask you the same question about this with the policies around education and curriculum, all this. What is the role of the WHO in these two areas? So Angela, start with you first.
I hope now that my video I feel almost like I'm disconnected when the video is not on. Can you hear me now?
We can hear you okay. Keep going. We all work here and we get it.
So I think for me, WHO is at a place which is really central, and they can really play a key role in actually ensuring that the issues that we are discussing are actually mainstreamed within almost immediately, and that they are able to talk to organizations, donors, and even countries to invest in ensuring that at least things are not left at the global level. Policies are not just there. Policies are not only at the country level, and that actually there's money that is actually invested, and they can actually guide and work with organizations, with nursing and midwifery organizations that are actually working in the health workforce arena, and also in governments and funders to actually ensure that what is discussed, whatever is going on, whatever investments are done, whatever is discussed at policy level is actually implemented, because we see a lot of things at policy level, but at implementation level, that is really lacking. And this is what we've seen over and over. I think for my last 16 years of working, that was what I've seen. I think it's also important that WHO also has a role to advocate, to actually work with, to be like an advocate as to why what we are discussing now is really critical. And I think that takes me back to the reason, one of the reasons why WHO was established. I think WHO was established for some reason to ensure that there's the structuring of the colonial aspects that were actually existing those days, that are still existing to date. So I think WHO, where it sits now, should actually play a really catalytic role in ensuring that policies are translated, money is actually directed to the right. And I think the word I'm going to say is right in terms of, we are talking about less and less of workforce, less and less of quality and quantity. Quality workforce in terms of the competencies and the skills are not matching the needs of the populations. Quantity in terms of the numbers, because the numbers are not enough. So what are countries supposed to be doing? Because countries cannot run away from the fact that as much as we are talking about attrition of nurses and midwives to other countries, frontliners going to other countries, countries also have a role to ensure that they actually have systems in place to retain the ones that are trained. Why did Tembi, for example, decide to go and work outside there? Maybe because the systems in our country were not conducive enough for her, and the governments were not supportive enough for her not to go out there. So, and at the end of the day, nurses and midwives need to put food on the table. They need to take their children to school. They need to do so much. So what are countries doing to ensure that attrition? So there must be a fair play in terms of the West, the countries where these nurses and midwives are coming from, and also the interface. The WHO playing a role in ensuring that they start balance, they start direction, they guide the countries, they advocate, they do what they ought to be doing at the end of the day, so that we see, at the end of the day, we are looking at a fairer world in terms of health and the systems and the places and the healthcare that we want to see at the end of the day. Thank you.
Great, thanks, Angela. Edward?
Yes.
What's the WHO role in your perspective? Yeah.
Yes, before I go into that, I wanted to add just one of my voice to how can we partner with the high-income countries in a culturally appropriate way. I think I want to start by appreciating, for example, the work that is being done by Seed Global Health currently, where they are ensuring educational institutions for nurses, for health professionals, partner with educators from the Western world. It all starts with aligning the priorities and the research agenda of the low-income country with that of high-income country. We actually start by sharing our needs. What skill set do we need? What kind of support do we need from the Western world? And once this, we basically describe, we need a midwife, maybe with this education, with this experience, and they actually get that person who will come and meet the local needs. The second point I also want to bring is we need to emphasize training health professionals from Africa, from African institutions, rather than taking them to the Western world so much. Because when we train them locally here, it means we shall bring the resources, the things that we need for training them, and keep them locally. They learn it while it is being used locally here, and then they continue to sustain it. I have seen so many nurses and midwives who have been taken to be trained in the US, in Japan, in Europe, and using sophisticated equipment that side. And when they come back here in Africa, those facilities are not available and they cannot even perform anything. Why don't we transfer that technology and train the people from the African institutions? The other thing I wanted to suggest is when writing program funding or research proposals, we need to conceive the idea together and write it together so that I'm not just a data collector, but I have also participated in conceiving the idea, in writing it, in executing it, and then I also become an author. So I think that is something that we need. Instead of our partners from the West writing the full proposal, getting the money, they just come here, here is the money, here is the proposal, you just collect me data. It's not capacity building to low-income countries. And then another thing is we also want to see principal investigators and co-investigators coming from the poor countries. Almost all principal investigators for programs, for research, are from the Western world. Why? We need to move into this situation and say, let us share these roles. You are a principal investigator in Africa, I am a principal investigator in the US or in Europe, and we do the work together. Then coming back to the question you had posed to me about World Health Organization, I want to say we want to see more positions for nurses and midwives created within the World Health Organization. I have seen UNICEF doing a very good job. UNICEF, UNFPA, a lot of positions for nurses and midwives are there. You find there is a midwifery advisor within UNFPA. I remember in the year 2011, WHO for the first time advertised for the position of a nursing coordinator. The advert ran for 3 months. After 3 months, it was deleted. And they said they canceled the position. Why? Why are we not having nursing advisors, nursing coordinators within WHO? If we really want to see roles of nurses being lifted, guidelines that are developed that are favoring the nurses, that take consideration of nurses, we want to see more positions for nurses and midwives within the WHO, just like the way UNFPA is doing. All these are UN agencies. Why are we not having more nurses in the WHO? I submit.
Wow, look, I heard an advocacy ask there for those advocates on the line for WHO to have more positions of midwives and nurses. I think that's great. And it's kind of a perfect way for me to give a few final highlights for today. First, big thank you to our speakers. As always, Angela, Edward, Tembi, you were just fantastic from the start to the finish on giving us so many things to think about. A few things I just wanted to summarize and highlight for everyone on the line. Again, number one, nobody has this, none of us have all the answers and nobody is perfect. What we're trying to do is be better. And I think that that's important as we figure out our goal for global health is to improve access, save lives. And so I think we can do that if we really start with some of our fundamentals. So recognizing local leadership, expertise, and knowledge. I like the idea, train local, keep local. Like, why do you keep moving people to New York to get training just for them to go back to Malawi and say none of the things look like they were in New York? Great, obvious point, but maybe we just need to make sure people pay attention to it. Actively engage the communities that we're serving. I mean, this keeps coming up with the nurses, the midwives, those, the communities where we work. I mean, this is not a fly-in mentality. It's the idea of, and there are plenty of people on the line who are living in these countries, invest in these countries, and are there all the time, but they don't always know how to involve locals. And, you can be an expat living in a community. It doesn't mean you're a local. You still need to make sure those local voices are there. And being a good ally is knowing when to allow other people to speak and you go to the background. So I think that that's a really important point. Create programs and policies that are community-led. I mean, we've been people-centered. We've been talking about this for a long time, but this is a drumbeat we need to keep going. You really have to keep looking around that table around policy and funding and say, wait a second, we don't have enough representation of those, for donors really to really help make these decisions. And we just need to take the time to do it. And even more around with research and papers coming out and our institutions that put forth these recommendation papers. Transform the health professional education and training programs. We talked about a lot about this. We got to take some of this stuff local at home. That means that books and research, that need to be done locally. And if people want to partner on education curriculum and things, that needs to start in the right places. You can have guidelines and standards, but they can't be US or British guidelines and standards. They need to be, global standards of which the pieces are really measured at the local level. And that's such an important point. We need to ensure that people are custodians of their own power. That means that we can't, under the guise of doing good work, still take the power away by saying, you're here for the research, you're here for the piece, but I'm going to put my name on it in the end. That's not really power. That's not a shared power. That's not really a partnership. That's just colonialism in the current day and age. So again, I want to thank our partners who organized this: Nurses Lead, Midwives Lead, Campaign Partners, C Global Health, Frontline Health Workers Coalition, the G4 Alliance, IntraHealth International, Nursing Now, Partners in Health and Smile Train, and to everyone who hung in there with us for our third partners. You really were the people who helped push us along, because we all want to do better and be better. So again, thank you to our speakers and our organizers. I am so honored to have been a part of this journey with you. I've learned so much, and I look forward to working with you all in the future.
Thank you.
Thank you.
Thank you. Thank you so much.
Thank you. Thank you. Bye.